Hello, I'm Andrew Coates. I'm a consultant cardiologist. I specialise in heart failure. I'm originally from Melbourne, but I have worked in the UK for many years, 25 years altogether. I've been backwards and forwards between Australia and the UK. So I've devoted my life to the treatment and evaluation of heart failure patients, both evaluating how to best treat patients, but also contributing to research advances in the evaluation of new treatments. I'm presently Scientific Director and CEO of the Heart Research Institute in Sydney. So we're a basic science research institute looking at the causes and consequences of cardiovascular disorder. Personally, as I said, I've devoted my life to heart failure. So a lot of that's been clinical trial evaluation of devices, novel therapies, as well as some cutting edge understanding of how best we can apply technology to the prevention and treatment of heart failure. Heart failure is a common disease because it's not a single entity. It's a syndrome of clinical symptoms and signs, which is the end stage of many separate cardiovascular disorders. It tends to get more common as populations get older, and paradoxically, as we get better at managing things like heart attacks, myocardial infarction. So the prevalence of heart failure is increasing as all the populations in the world are getting older. Heart failure is well managed in Australia. It's a complex disorder that's becoming more prevalent as populations are getting older. So to fully address the demands requires a joined up approach. It requires multidisciplinary approach involving physicians, primary care and secondary care, nurses, pharmacists, dietitians. We all have to work together because we're supporting an increasing burden of patients by number and also the number of comorbidities for each patient. So critical is teamwork. STRONG-HF was a really important trial. It was a pragmatic trial design. In other words, it wasn't heavily sponsored. It was relatively inexpensive, conducted mainly out of France. And it really compared two strategies to how to manage patients who had an acute admission for acute decompensated heart failure. Strategy number one was conventional management, which involved doing what you could do in hospital, and then the patient being discharged for outpatient care. Strategy number two was an intervention, which had an accelerated regime for rapid evaluation of the patients, rapid up-titration of guideline-directed medical therapy, and importantly, the use of N-terminal-proBNP to assess the patients during that rapid period. So over the subsequent 4 weeks from discharge, patients would be evaluated. The opportunity was taken to increase the doses of guideline-directed medical therapy as quickly as possible, and their response to treatment and their clinical status was assessed by regular N-terminal-proBNP evaluation, which I think was a critical part of that overall strategy. In the STRONG-HF study, N-terminal-proBNP was used as a way of evaluating whether patients were getting well controlled. So it had multiple purposes. If the dose of guideline-directed medical therapy was to be optimized, then it needed to be increased, and then you could look at the results of N-terminal-proBNP to say whether the patient's coming under better control. So ideally you're seeing a fall in N-terminal-proBNP towards more healthy levels, more normal levels, but if it was found to be high, then of course the physician could then take the opportunity to evaluate whether the patient was deteriorating, whether they might need more treatment, particularly increase of diuretics. STRONG-HF study was a study of two approaches to how to manage acute heart failure in a hospital setting and the subsequent discharge period. So we can't dissect out which elements made a difference, but my take-home message from STRONG-HF is it gives us support that it's safe and effective in terms of major outcomes to be faster and more aggressive with up-titration and initiation of guideline-directed medical therapy. And intimately linked to that, the utilization of natriuretic peptides, N-terminal proBNP, to evaluate whether the patient's being well managed, whether they're responding to treatment, or whether they are showing signs of incipient decompensation was critical as well. Like all things in clinical care, new ways of doing things have to be incorporated. People have to get used to it. And ideally, we want to look at a new way of caring and replace what we're doing rather than just adding it on top. So the opportunity of STRONG-HF is it shows us a clear message that a more rapid, more urgent sense of up-titration of guideline-directed medical therapy is important, that there is value in utilizing N-terminal proBNP to guide decision-making, but the barriers are how do we get the educational message out, how do we support doctors to take this new approach, and that's critical for educational meetings to support doctors to adapt what we now know is possible. We've learnt a lot over 20, 30 years that industry plays a critical part. A, they develop new ways of doing things, both diagnostic and therapeutic. B, they can fund and support the trials that give us our evidence. But C, they're very important in the educational initiative. We need outreach. We need to have local meetings where key opinion leaders talk about issues. Local doctors see their local expert, quizzing the experts from outside, understanding, and they get a chance to frame questions about real cases they see. So industry and our commercial partners are critical in that whole ecosystem of obtaining the evidence, evaluating it, and making sure that doctors are now using it. In addition, they can often develop new ways to accelerate and improve care, such as improved diagnostics, such as the use of N-terminal proBNP, which can give you an insight into the patient condition with heart failure that we simply can't easily get any other way. The critical thing about studies like STRONG-HF is we have to learn from them. It's not enough to just do the studies or even publish the results. We actually need to work out how best to integrate it into our care. So that involves education, support of doctors, looking at how we manage things presently, and looking how we can incorporate the important elements of studies such as STRONG-HF into our practice so that we can achieve the benefits that the study shows are possible.